Joining ASTHO for a webinar on financing interventions that address the social determinants of health. My name is Anna Bartels. I'm the Director of Clinical to Community Connections at the Association of State and Territorial Health Officials, known as ASTHO. Next slide, please. ASTHO is the national consensus-driven organization representing state and territorial governmental public health. Next slide, please. So today we'll be learning about how public and private insurers are addressing financing interventions that address social determinants of health and provide social services, including a discussion on what motivates an insurer to address these interventions, and also what are some promising practices that are happening right now in the field. Next slide. So as brief background, a strong base of evidence supports the connection between an individual patient's unmet health-related social needs, such as housing, transportation, food security, unmet utility needs, or interpersonal violence, and the linkage with increased healthcare utilization and poor health outcomes. We also recognize that these individual health-related social needs are often a reflection of the broader social determinants of health, which are the structural and societal factors that create the opportunity for health and wellness in the first place, and which may fall beyond the reach of an individual sector. So now we see that both private and public payers are rolling out strategies to improve the social determinants of health as a way to improve the effectiveness of care, reduce healthcare costs, and prepare for a shift to value-based payments. Next slide, please. So today we're pleased to be holding this webinar as a platform to hear from 3 speakers representing both public and private insurance. We'll first hear from Kate McAvoy, who is the Director of the Division of Health Services at the Connecticut Department of Social Services. We're also joined by Michael Monson, Senior Vice President of Medicaid and Complex Care at Centene Corporation, as well as Mikkel Moore, who's the Senior Vice President of Community Health at Intermountain Healthcare. Please note that a recording, which includes slides, will be posted on ASTHO's website following this webinar. We also invite you to enter any questions or comments into the chat box as Bill directed on your screen. We will be taking questions after all 3 speakers present, but we encourage you to send in your questions as they come to you. So Kate, thank you so much for joining. If you'll hit the next slide, I'll turn it over to you.
Great, thank you so much, and good afternoon, everyone. As was announced, I have the privilege of serving as the Medicaid and CHIP Director for the state of Connecticut, and I wanted to thank ASTHO so much for the opportunity to join you. Also particularly excited about the range of perspectives on the call. We are a public payer, of course, in that we're a Medicaid program, so I wanted to share briefly with you some context about our program and then give you an overview of the ways in which we've been focusing on determinants of health. So if I could ask for the next slide, please. From a context setting standpoint, our Medicaid and CHIP program in Connecticut serve about 21% of our state population. We are an expansion state, and we've seen significant growth since 2012 in the uptake in our program, including about 250,000 people who are served by our expansion group, HUSKY. That is a non-exclusive example of our uptake of the range of choices, the policy levers under the Affordable Care Act. You can see we have also really availed ourselves in rounding out the array of preventive services. We cover a very broad range of services, including medical, behavioral health, and dental services for both children and adults. And that is a really important premise of our reform agenda. We've also availed ourselves of many of the strands of integration authority, such as health homes for individuals with serious and persistent mental illness. And also building on that, we have pulled down a lot of the resources and strategies in the area of long-term services and supports, and you see some of those mentioned there. Connecticut is also the recipient of a state innovation model test grant. And not only was the ATA a major policy impetus in Connecticut, but it gave us working capital to really push the envelope in many areas that ultimately have nexus with determinants. So we've been very, very privileged to have those new resources. We are quite different than most Medicaid programs in that we have not substantially relied on a capitated managed care approach. Instead, we are self-insured, like many large employers. which has given us, in our view, a lot of flexibility in terms of the strands of the policy interventions that we have selected. We've also been quite elastic in our use of Medicaid state plan authority. So we have not used an 1115 demonstration authority, which I know a lot of vanguard states in this area have, but we've really been able to push the envelope of our state plan to cover a lot of services and supports that have bearing here. We also have, concurrent with a lot of the work on healthcare coverage, access, and the service array, we've also had the benefit at the gubernatorial level of focus on justice reform and also a very major effort around elimination of homelessness. These have been complementary efforts that we see as directly related to enhancing the impact of Medicaid in these areas. May I have the next slide, please? So we did migrate fully away from capitated arrangements. This was fully effective in 2012. That was also the year we became a full expansion state. We have built on the service array that is a hallmark of our program to really consciously embed a range of strategies around social determinants. And I'll be sharing a bit more detail in just a moment about these, but really they span a spectrum from kind of global strategies at the federated level. An example of that is we have undertaken a statewide structure with administrative services organizations acting as our partner, notably embodying new types of intensive care management strategies. And I'll share more about that. That's really been at the statewide level and designed to support both members and particularly primary care providers in engaging with people and effectively addressing complex needs. I mentioned the integration efforts, of which Health Homes is one example. We also have had, fortunately, history with an applied demonstration grant, Money Follows the Person grant, which, as you know, is a systems change effort in long-term services and supports that has been longstanding funded by the federal government with the aim of increasing choice and self-direction for individuals with disabilities and older adults. Our Money Follows the Person effort spans a lot of different strands of work within systems change, but one very, very important part of that is we are marrying up Medicaid resources with housing vouchers. So we call our model Housing Plus Services, and I'll share more about that. We also have built in attention to social determinants in our implementation of primary care footed shared savings initiatives that have features of care coordination that build on person-centered medical home, but also require nexus with community-based organizations. And finally, and this is unfortunately not fully updated slide, I apologize, but we have received legislative approval to cover transition and tenancy sustaining services, or we use a sort of global term, supportive housing services under our Medicaid state plan. This is the most recent and most exciting accomplishment, again, using the auspices of our state plan. May I have the next slide, please? This is really a graphical depiction of our approach. It's been an evolutionary curve. We really started in 2012 with inaugurating a major person-centered medical home push in our state that's designed to equip providers to identify and meet people where they are in their goals around primary care. We, as I said, implemented a statewide intensive care management effort that spans our partnership with several ASTHOs for medical, behavioral health, and dental services. ICM is not generic. It's really applied very broadly. It includes nurse care management teams with community health workers, but also peer supports for people with lived experience in behavioral health or SUD, and dental outreach teams that engage with primary care practices, particularly around pediatric needs and maternal health needs. We've layered on to those kind of foots of our program. We think prevention and integration and coordination of care is really the fulcrum point of everything we want to do. We've layered on pay-for-performance approaches, the ability to analyze and stratified data. Our self-insured status has enabled us to create a fully integrated Medicaid claims set. We're using a Johns Hopkins tool to risk stratify and perform analysis and to push data out to primary care practices to help them improve performance. So those are our kind of footing, and we have built on that the expanded care coordination efforts, really pushing that to more community-based models. The pieces particularly around housing supports with the nexus with housing vouchers, and then our first big foray into use of upside-only shared savings arrangements, again, building on that PCMH program. Ultimately, our aim is moving that out to a local multidisciplinary network model, and we're really focused on primary care right now, but want to build that out for the specialty services, long-term services and supports, and continue to enhance the nexus with the CBOs. May I have the next slide, please? This is really just an articulation of our aims, and I think everyone resonates with this, and especially in Medicaid, we really see opportunities around economic security, generational change, intact and resilient families. And then we really want to articulate this distinctly, and that is the piece for equal opportunity for people with disabilities, which has not historically been as simple a proposition. So really keeping that very top of mind in all of the work we're doing from a reform standpoint. May I have the next slide? So really specifically a little bit more about the strategies for social determinants. I want to start with something that may seem pretty basic, but for us it was very instrumental. It's a starting point that enabled us to really crystallize how we're defining the orientation of our program, and that is a program-wide adoption of a definition of person-centeredness. We really felt like this was an important route of saying our members are our focal point, our members and their circles of support, whether that's family or chosen family, other supports, and really implementing this we thought was instrumental to establishing a right order of things, and that's the member is the origin point of where he or she would like to focus on health goals, and that helped us kind of set that standard. We also felt from a threshold standpoint, and I think most of us have really incorporated this very meaningfully in programs across the country, whether publicly or privately funded, and that is the piece around screening. We were early on really insistent that the screening questions around determinants be embedded as a starting point of our intensive care management assessment. And really, if there was a positive response on any of these, that the team, the intensive care management team, and notably as that became rounded out by community health workers, would address that set of issues before looking to engage on health goals. Obviously, these can be very inhibiting if not properly addressed, and can really intercept an individual's ability to even define health goals. May I have the next slide? So as we began to mature in this approach, identifying people's needs and equipping the primary care community through in-kind supports of transition and transformation planning, but also enhanced funding. We raised our primary care rates and held them at a higher level. We paid them enhanced rates for year-over-year performance on quality. But we also built on that with this set of intensive care management strategies I discussed that are deliberately, as I said, not generic. They're very tailored to the particular needs of various communities, and really enables us to hone in, using especially that data set of claims data, hone in on where we have the greatest opportunity to support people in change and improvement, not only in their health outcomes, but also in their experience of care. An example of where we really kind of built out that care management strategy was our Health Home initiative, which, based on what we could identify and learn from both members' direct experience through CAPS, but also our data, showed a set of opportunities around improving services and supports to individuals with serious and persistent mental illness, and also high Medicaid claims, we have partnered with local mental health authorities, their regional entities, and their social services partners to embed the medical tools through APRNs in existing behavioral health footed organizations that already have the experience and trust basis with members and really lacked that strand. They were already well connected with community-based organizations and had the BH expertise, but really building in that medical capability to address co-occurring conditions and acknowledge the very, very serious mortality rates and complexity for people with SPMI. The health home approach was our early integration effort, and it's really yielded tremendously. Next slide, please. So we built on that sort of threshold work, again, primary care providers with better capabilities and receptivity, the early integration efforts, and intensive care management, by recognizing that we wanted to migrate out to a more community-based level. We acknowledge the state does not have any kind of premium or special expertise in working with members in Medicaid. And in fact, many community organizations, notably health centers and the larger primary care practices, have a lot of experience and trust basis. So we deliberately kind of went that next iteration of saying person-centered medical home standards were our requisite, and we would build on top of that additional features of care coordination, notably behavioral health integration, attention to children with special healthcare needs, a focus on disability competence, and also the class standards for health equity. We would also layer upside-only shared savings arrangements in there. And finally, most notably important to social determinants, is that we required entities with which we contracted in these arrangements to be explicitly connected to a range of community-based organizations. So we gave specific examples like agencies on aging, like housing providers, really endeavoring to set up working routine feedback loops and that braid the resources that we otherwise are funding through state means, state and federal funds. Finally, and most exciting to me, is really having evolved now to build on the historical work we've done in Money Follows the Person, and also through a pretty large portfolio of state-funded supportive housing, both of which enabled us to prove out the proposition that if you provide people with stable housing, a housing-first approach, that in and of itself enables engagement that will improve health outcomes, will reduce the chronic use of emergency room and the cycles that we were seeing, which were just totally unwelcome, which people would go frequently to the emergency room, have hospital stays related to acute onset of conditions, be discharged to nursing facilities, not meet level of care, and often be discharged again to unstable housing situations or homelessness. Recognizing that we need to intercept that cycle, we will be implementing a state plan option in Connecticut Medicaid to cover those supportive housing services, both the transition services to get them connected with and stable in housing, and then tenancy sustaining services to make sure that that housing is not intercepted and that people are supported in their relationships with landlords and fellow tenants. And we have braided Medicaid resources with specific new appropriations for housing vouchers. I'll wind up by saying that this initiative is important in its own right in that it builds housing into the portfolio of Medicaid, but it's also enabled us to do a couple of other things, and that's to start to routinize data matching across domains, which is a hard row to hoe for state entities often, and also to transcend the specific lens of budget, line item budget, and really say what can we look at in terms of optimizing result across sectors, in this case both the expenditures on housing and the expenditures on Medicaid, but also looking at opportunity costs and opportunities for stabilization of people who might otherwise be just served or have other expenditures within the state budget. So I'll wind up there. I've tried to capsule the work we're doing, but just to say that I think all my fellow directors in Medicaid see this as the most important next generation work for us as a public payer. And these are some examples of the really interesting and generative work that's going on across the country. Thank you.
Thank you so much, Kate. So now we're going to turn to Michael Monson with Centene Corporation. Michael?
Thank you very much. Well, I want to say thank you very much to ASTHO, and I feel like it's very much a privilege to be part of this conversation today. This is a very important topic whose time has come around the social determinants of health and how we pay for it. And so I feel very privileged to be part of this panel and excited to share what we as a company are doing. So if you go to the next slide, please. Just very quickly, for those of you who are not familiar with Centene, we are the nation's largest Medicaid health plan. We operate in 32 states, nearly 15 million members across all our product lines. We're also the largest exchange in the country. Our focus is exclusively on government-based insurance and working with individuals who are lower incomes. Next slide, please. So, as is true in most people who work in the Medicaid arena, the social determinants of health are not a new thing. We've been working on social determinants of health for decades. We like to say it's part of our DNA, actually. We have more than 50 programs that we've been operating for many, many years across the country, as you can see on this graphic, across the many different components of social determinants. It is an critical part of what we do every day to work with our members to help them live healthier lives. And it is something that we feel very deeply passionately about. And to that end, we've got several, if we go to the next slide, several programs where we've been very fortunate to show some results. So I'm not going to read this slide to you, but a couple key things to think about. In housing, in one of our states, we've been working with integrating with the homelessness system and data to coordinate how we actually work with individuals to get them into care sooner, and received a 9% reduction in patient behavioral health visits. We've done a lot of work around ride shares. As people know, non-emergent medical transportation is often a severe pain point for people in terms of not having either access to it or the system not being particularly good. And by using some of the ride share programs, we have seen 15 to 18% reductions in cost around the system, which means that we're also getting more people out because we can use those dollars more effectively. And then we've been doing quite a bit of work around how do we think about who's at risk. And so as every health plan, we have a risk score that we calculate for our beneficiaries in terms of so we can identify who we need to be focused on. What we did was now layer in on top of the medical components, the social determinant components, and we've actually were able to enhance our predictive power by 30%, which we are very excited about. And that's being rolled out across the country now. Next slide, please. But while all of these programs are great, fundamentally, what we have seen across the ecosystem around social determinants is a lack of sustainable programs. Lots of pilot programs, of which we do as well. Lots of grant-funded programs, of which we do as well. Very few sustainable programs. And so, to answer that problem, we formed Social Health Bridge. Next slide, please. So. You can just go through the, yes, thank you. One more. Thanks so much. Sorry, I got to get rid of those graphics. So we asked our question, why are there no sustainable programs? Because social determinants is now finally getting tons of attention. We have willing buyers on the health side. We have willing suppliers on the social side, but we do not seem to have a functioning marketplace that lives in between. And so we think that there are three reasons for this market failure. So one is that there are deep, deep cultural differences between community organizations and healthcare entities. Linguistically and culturally very different. And literally, we can use the same words and mean different things, and oftentimes we're talking different languages. So it's a non-trivial component to having problems between the two areas getting together. The second thing is that the social sector is particularly fragmented and also operates at a fairly subscale arena. And so what does that mean? That means that your typical affordable housing community might have 150 people in it, but those 150 people are attached to 10 to 20 different health entities, whether that be payers, hospitals, physician groups, post-acute providers, you name it. And so when you start slicing and dicing that, the administrative cost and complexity for both sides to work with each other is very high, let alone trying to move into a pay-for-value arena, which healthcare is attempting to do. And if you're going to live in a pay-for-value arena, you can't slice 150 people 20 ways because the numbers are too small to do that. You need at least 500 people to be in a pay-for-value arena. And then finally, there's a lack of a standardized product, and shame on us in healthcare. We really like standardized products, and if we don't have, and if you come to us without a standardized product, we look at you like you have 10 heads, let alone half a dozen different types of non-standardized products coming from the social sector. So we look at that and say, well, we feel like we have a responsibility as the largest health plan working with lower income individuals. We have the size and the scale to think, to realize that there's a way to solve this problem. Next slide, please. And so that's why we built Social Health Bridge. So Social Health Bridge is meant to be our attempt to help move this industry towards a sustainable solution. And so what does that mean exactly? So we actually sit between the social sector and the health sector and have a financial and interventional layer. And so we do that because we aggregate scale from both sides. And so what does that mean exactly when we talk about aggregating scale? So what we do is we take, in any geography where we are going to be operating, we take every single one of a specific type of community-based organization. So we're going to be starting with affordable housing. So we'll have every affordable housing community signed up in our program, hopefully. And because we've done that, we have suddenly achieved scale. Because instead of talking about a couple hundred people, we're talking about 5,000 to 10,000 people. And then because we've aggregated that scale, we can actually then go to the health side and contract with them at scale too. So we're now bringing the administrative complexity down for both sides. Equally importantly, we have developed a standard product. And so what that means is that every one of our community-based organizations that we're going to be working with is going to be delivering a specific intervention. It's really a community health worker intervention. We all know, everyone on this call knows, that community health workers work. The problem with community health workers are they're very expensive because each health entity is sending them out into the world. So what we're going to do is we're going to take that model and flip it on its head. So we're going to put a community health worker in the middle of one of those affordable housing entities, or to the community centers that we'll be working with and the homeless shelters we'll be working with. And so we can actually now take that person and we can work with them at scale. It's very important because we can also then have them all working on a standard set of processes and protocols and procedures. And all of that's really important because not only does it lower the cost of delivery, but because everyone is working on a standard model, we can go to the health side and say, don't just pay us because these are good things to do. Pay us because we're going to deliver something for you at value. And what that means is we're prepared to go at risk with the health entities that we work with on their quality measures and ultimately on hospitalizations and ED visits where we believe we can have a significant impact. And so you can go to the next slide, please. And so when at the end of the day, and I'm sorry, there's some graphics, push those through again. One more. Thank you. So what does everyone get out of this? Well, the healthcare entity gets an easy way to engage. Instead of having to deal with many different contracts, they can deal with one. Equally important, they can track performance and they get to pay us on a risk-based manner. So if they're not receiving the results that they want to be receiving in terms of their outcomes, both financial and quality, then we're at risk for that and we have to pay them back. The community organizations get a steady stream of funding because we're actually going to pay them now. Because we can bear risk on this, we will pay the community organizations for the work they're doing with us, as well as giving them some portion of the upside. It gives them also an easy way to engage with the healthcare ecosystem, and equally important, gives them an opportunity to differentiate themselves as they go for grant making and who work with others. So ultimately, we believe that this is a real opportunity to actually take, instead of continuing just to have grant funding that goes into this sector, but to actually create a model that can bring the two parties, the two sectors together into a financial transaction that improves the outcomes for people, most importantly, has money flowing from the health sector to the social sector in a sustainable way, and truly enables the social determinants to come to life. And so I thank you very much for including me in this presentation today.
Thank you so much, Michael, for that presentation. Again, if you have questions, please feel free to enter them to the chat box. We will come back to discuss this more following our final presentation. At this point, I'll turn it over to Mikkel Moore from Intermountain Healthcare. Mikkel? And Mikkel, I believe there might be, if you press *6, it may be able to unmute your phone line. I know there's been some connectivity issues. Okay, well, let me connect. While we wait, we did have a question come in. So Kate, if you're still available, maybe we can pivot back to answer this quickly from Connecticut.
Sure.
Why did Connecticut move away from or not implement Medicaid managed care? And then secondly, how do you, if you do, partner with your state public health agency?
So thank you for that question. We moved away from capitated managed care because despite rigorous contracts, we had real challenges with transparency of information. I think that the premise of encounter rates really was, encounter data rather, a challenge for us, and it also was something that was of great interest to stakeholders, is knowing more about what services were being provided and what configurations. We also did see a continuing cost trend increase in our experience with capitated managed care, and since transitioning, like I said, we've been able to create a fully statewide claims data set. So that's been an incredibly important derivative of becoming self-insured. We've used that for data analytics, risk stratification. We've also, as I said, pushed a lot of that data out to primary care practices so that they understand more about their panels. And also, we've been able to hold our per member per month remarkably consistent since 2012. In fact, reduced it over time. So some of those things I think were the major drivers. And then that question around partnership with our sister Department of Public Health, we've been very actively partnering with them, particularly in context of our SIM model test grant. We have been in process of developing ideas around health enhancement communities with them, and then also really focusing on how we look at building in the attention to population health within our value-based approaches in Medicaid. So that's been really important work under the state innovation model.
Great, thank you so much. I do see Mikkel's name. Mikkel,
are you able to hear me now?
Yes, thank you.
Okay. I'm having some technical difficulties, so I apologize. I will attempt, if you'd like, for me to do my presentation now. If it kicks out halfway through, I apologize. Shall I proceed?
Yes, please go ahead.
Okay, great, thank you. Let's go to the next slide. So I appreciate this opportunity to present, and hello to Kate and Michael and my colleagues who involved in our presentation today. Intermountain Healthcare is a little different than a Medicaid office or a Centene in our work. And so I'll try to share our role as both a payer and a provider in thinking about our opportunity to impact the social determinants of health. Intermountain is a regional player. We have 24 hospitals throughout the Intermountain West, as well as virtual services and a health plan that serve this area. And our objectives are really to think about how we take an integrated approach to addressing the social determinants of health. So next slide. If you think about our reach at Intermountain, we have a health plan that insures people through Medicaid, the individual plan, available through the exchange, Medicare, commercial, et cetera. And we're also a large institution. Are you able to hear me?
Yes, we can still hear you. Or we were able to hear you. Are you still there?
Can you hear me now?
Yes.
I'm so sorry. If that happens again, I might have you continue. The computer kicks me out, and so I'm logging back in each time. So as a large system, we're really thinking about how do we use the social determinants of health to change the way we deliver care for our members, but also in the way we clinically deliver services in our system. And do that in a way that gives us the opportunity to change address the social needs of the individuals we serve, but also influence the social context in which people live. So we're also thinking about our organization as a major purchaser and a major employer, and thinking about our ability to influence upstream from those social conditions that our members and patients are facing. Next slide. So our mission is helping people live the healthiest lives possible. That's our mission as a health system. And as we think about how to apply that, we're certainly thinking about the health care that we deliver through the services we provide to members and to patients, but also thinking about the way we contribute to people's individual behaviors and the social and environmental factors that you all know so well. Next slide. I'm going to share a little bit about a demonstration project that we've had underway for about 6 months now, where we're thinking about how we address this mismatch between spending on healthcare services that primarily goes to medical or rescue services for sick care versus those areas that we think that we all know contribute to health and well-being overall, and trying to do this in a way that doesn't just increase the healthcare spend.
Nicole, I think we can still connect with you by phone. Can you hear us?
I can hear you. Can you hear me?
Yes. So I think when the visual drops, we can still hear you by phone.
Okay.
So you can just moving verbally.
Okay, we'll keep going. So let's go to the slide that says meeting social needs and addressing the social determinants of health. We really wanted to devise a way of thinking about this as a health system that would allow us to think about the way we provide clinical care to individuals and impact the social needs that people have as we're delivering that clinical care, but also thinking about how we change the community context in which people are living so that we influence their environment and their opportunity for health. So we launched, next slide, the Alliance for the Determinants of Health here in Utah, which is you'll notice it carries different branding than Intermountain Healthcare. This is really a community-based collaboration. And it is a collaborative approach to addressing and achieving health equity in our communities. We really wanted to solve this using all of our assets. So taking our health plan as well as our health system and thinking about the way we could also change context in our community. So we selected 2 communities where we saw health disparities of 10 years difference in life expectancy from east to west or based on income, demographics, and other things, which is arguably pretty good compared to lots of urban settings in our country, and sought to really change the opportunity for health in these communities. If we go to the next slide, you can see images from those 2 communities. Weber and Washington counties, they're at opposite ends of Utah and are different types of community in terms of their urban or rural setting, political bent, and kind of the age of the community as well. One's a very old community, one is a newer community, and so on. But they shared some things in common: lower than average life expectancy, high behavioral health needs in certain zip codes, and high rates of emergency room use for non-emergent needs. These weren't the only communities we observed in this, of course, in this state, but the communities where there were both the disparities and a community interest in addressing the inequity. And so we created a collaborative approach to addressing both the social needs and the medical needs of people living in these communities. If we go to the next slide, you can see a graphic of all of our partners involved in this work. And while I won't get into the details of everyone who's at the table, I want to point out a few things. First of all, that we have created an alliance in each of those counties, so a Weber Alliance and a Washington Alliance, as well as have a state, we have state level support in the Departments of Workforce Services, Health, Medicaid, the Governor's Office, Human Services, et cetera, so that as we're innovating in each county, we're also thinking about statewide implications for policy. And we're sharing our learning with people like you as well as others so that we can, as much as possible, use this information to influence health outcomes across our country. So what does this alliance really do? Let's go to the next slide, which is a graphic describing the 3 stages that the accountable health communities are using around awareness, assistance, and alignment. We have developed our model in a similar way, but placing those opportunities for awareness throughout a community. So in our alliance, we have local mental health authorities and federally qualified health centers, community-based organizations like the Food Bank or United Way, housing supports, et cetera. Intermountain Zone emergency departments and clinics are connected, and so is our health plan, Select Health. In each of these settings, we are screening for people's social needs. So that looks like using the Prepare tool or the Seek tool in certain clinical settings, and implementing those tools in non-clinical settings like the community-based organizations. With our Select Health membership, we're using a risk prediction model, much like Michael described as being used at Centene, to screen for social needs. When a number of social needs are identified, up to 4, an individual is connected to resources with kind of traditional referral resources using our community's 211 resources that care managers can see and have access to and can connect people to. But when people have more than 3 or 4 community health needs or social needs, or the person caring for them feels like they need a community health worker, they are connected to a community health worker who, whenever possible, gets a warm introduction by the care provider and then does follow-up visits to the home, may come into the emergency department, may go to the local mental health authority, et cetera. And these are individuals that are hired from the community. These team members, both the community health workers and the various organizations involved in awareness, are connected using a digital platform. We've contracted with Unite Us to build a network in each community that we're calling Connect Us, that will help support navigation to resources, as well as facilitate an individualized social care and treatment plan, and then connect people to community resources. The data that we collect through that process of navigating will also inform realignment of our social services and structure within these 2 counties and influence the state. I loved Michael's reference at Centene to grant making combined with other things that we have the opportunity to influence. We believe with the information that we'll be able to provide from this, we'll be able to inform the way we're making grants at Intermountain, but also the way others are funding various support services that are helping to improve things and address some of the gaps that we're finding already in housing support, food, transportation, et cetera. Next slide. So our ambition here is to improve health outcomes for the people we're directly serving through the Alliance for the Determinants of Health in Weber and Washington counties, but also think about how we reframe the relationship between healthcare at an integrated system level, both plan and provider, with the community infrastructure to create a new definition of health at the community and state level, and use that information to influence policy to enable this work more fully. And that certainly will be necessary with others and in partnership across the country. As we do this, if we go to the next slide, the Intermountain Healthcare Anchor Initiatives, we are also trying to influence all health systems to think about their opportunities to influence the social context in which we live. At Intermountain, we're spending nearly $3 billion on non-labor spend, so those are purchased services. We are looking at how we can support more locally owned companies and expand more sustainable practices in our community as a way to improve health. Also thinking about how we hire vulnerable populations and give people we hire into entry-level jobs opportunity for career growth. We have a balance sheet or assets we need to maintain as a part of good business practices within healthcare. We're using some of those resources to invest in the social needs of our community by helping services to expand that are needed to improve health and well-being, and also just improving local investments. And finally, trying to do so in a way that improves sustainability, because air quality and environmental conditions are absolutely contributing to health and well-being in our communities. Thank you, and my apologies for our technical difficulties. I hope that, that this has been smooth enough for you to hear my message. Thank you.
Thank you so much, Mikkel. I do have an early question for you from our chat box about the logistics of the $2 million a year. Could you describe a little bit more about where that $2 million investment came from? And then also, is that entirely from Intermountain, or do other partners contribute too?
So Intermountain Healthcare provided the seed funding for that. Really out of operations, we set aside $2 million per year for each community. That money was granted to one of our local United Ways to act as financial intermediary. There, we've organized a financial distribution committee that now will oversee on behalf of the community the distribution of those funds for the stated purpose of making the alliance work. Other donors have contributed dollars as well. So we have private donors, banks, contributing so far, as well as other agencies bringing some match dollars through local mental health authorities, FQHCs, et cetera.
Great. And will that money continue past the 3-year pilot program, that blended funding?
So the intent is that this act as prepayment, essentially, for what we prove out to be true, so that we can pre-fund some of the resources that are needed in order to address social needs, identify those barriers, and then solve for those from a policy perspective or a redesign of support services. We are using a third-party evaluation so that we can closely track impact on medical spend, but also impact as we realign services, so that we're really doing our own pay-for-success model with the intent that we create a sustainable model that can continue beyond the three-year mark.
Great, thank you. And Michael, I'd like to direct a question to you on behalf of Centene. So you described the benefit to community-based organizations that will be participating in the social health bridge. Where do you see the benefit for Centene to assume the risk?
Sure. So thanks for the question. So first, we feel, for us, we feel as the leader in the space, it's our responsibility. So it's just part of our mission as an organization. But on top of that, we do also feel that this is, the problem we have here is it's kind of a tragedy of the commons. Hopefully not to give anyone flashbacks to their microeconomic days, but the problem is that you need a first actor to kind of bring a lot of this together. And so we want these types of services available for our own members, but it's too expensive for us to do it on our own. But collectively, when we can do this all together, we actually can do this in a cost-effective way, again, in a pay-for-value situation. So, so there is a direct benefit for our members because they'll get a level of intervention that we couldn't, nor could anyone essentially provide to them by themselves. And then also it's part of our we feel it as part of our obligations to our customers, which is the states, our state Medicaid partners, to help bring them solutions. So we get value there. And then finally, we do think that this is going to be a going concern. We think that there is a business here. This isn't a business that's going to, I don't think this is a business that, people are going to run to the bank on, but this is a business, and so that this should self-fund itself, and that it becomes a going concern as part of our operations.
Great, thank you. And then this is a question for Centene and Intermountain. Can you each say a little bit more about your role in policymaking? For example, would you advocate for state and federal policies that affect the social determinants of health, such as SNAP, or just funding for public health agencies? Or what is the role that you have with policymaking in general?
This is Mikkel. I'll start, I guess. We view our role as maybe threefold, if you will. One, we want to bring real context and experience to policy making as we're doing the work. So since we launched our alliance in January, we're encountering lots of barriers to implementation that are giving us great examples to take to both state and federal policymakers to help them understand what gets in the way from risk of inurement or Stark Law violation, just difficulty in, differences in eligibility. So we're trying to bring some of the practical, what gets in the way information to policymakers to influence state and local policy. At a state level, I mentioned that we have I probably didn't call it this as I was presenting, but we have a state advisory council that the lieutenant governor and I co-chair in our state, so that the alliance is actually influencing the way Utah is thinking about Medicaid expansion and the connectivity of services between health and others. And then we're similarly participating in a number of federal policy discussions. So yes, we will engage in conversations around SNAP and housing and other things, but also trying to directly influence the way healthcare works with those other agencies at both a local and national level.
Yeah, and I would add, I was very similarly, we would work at both the state and the local level to advance issues directly tied to the health components, as well as just around advancing good public policy. So we have through either our trade associations or directly. And we've also, through our research center, our Centene Center for Health Evolution, we have published research around social determinants to help advance policy. So we do think that that is absolutely something that's our responsibility to help bring that insight and help advance the conversation in a way that leads to good policy that has good outcomes for people.
Great, thank you. So I'd like to give a moment, if anyone would prefer to verbally ask a question, you can unmute your phone line by hitting *6. It should unmute your line. So I'd like to pause for a moment and see if anyone would like to ask any final questions. Okay. If you could go to the next slide, please, Tikwam. So I want to say thank you so much to our speakers. We're very excited about the work that you're doing, and we're pleased to have you join us today. If for those on the phone, we would greatly appreciate the chance to know what you thought of this webinar. Please fill out the evaluation survey on the screen. It's also shared in the chat box. Similarly, if you have any questions that you think of after the webinar today, we invite you to reach out to us. Our contact information at ASTHO is on the screen. We'd be happy to connect you with our speakers or connect you to resources if there's a specific topic you'd be interested in learning more about. So again, thank you so much to our speakers. Thank you all for spending an hour with us, and we hope you have a great rest of your day. Thank you.